Firstly, thank you to the CLL Advocates Network for inviting me here today to speak about some of the work that Leukemia Care has been doing and also to learn more about the work that the different organisations represented here have been doing for CLL patients. I'm hopefully going to provide some UK examples of the work that we've been doing. Before I start, I'm aware that we're a UK organisation and the UK has a history of charities. And some of the other organisations, we have a mix in the room. Some are much younger organisations, some are volunteer-led, some, like us, have been established for many years. So what I say, it may not all be appropriate for everybody who's here today, but the thing to remember is to take the ideas of what I say and tailor it so that you know what is appropriate for your organisation. Base that on the amount of time you have, the amount of money you have, what other work that it is that you have to do. So a little bit of context about Leukemia Care. We provide support to anybody affected by blood cancer, patients and their families. We're quite a large organisation. We've been around for nearly 50 years and we have 18 members of paid staff. But because we have such a wide remit, even though we have quite a lot of staff, we do not have unlimited resources. We have a lot of work to do with what we have. I head up our campaigns and advocacy team. There's only 2 of us, but we do all of the charities, campaigns, policy work, health technology appraisals. That can be 20 to 30 new drugs every year in the UK. And we have to work effectively with different stakeholders so that we can achieve the objectives we want to achieve. So back to the question about engaging with the different stakeholders to improve access. In order to answer that, we need to answer 3 questions. Firstly, what do we mean when we talk about engaging? Secondly, who are the different stakeholders we need to engage with? And thirdly, access to what? So when we talk about engaging, we mean different things in a number of different situations. But overall, the theme is trying to change perceptions and trying to drive change for the patients we represent. This may be through working together on an issue, or even if you disagree with a decision that's already been made or the state of affairs in your country, you might be publicly calling for change. The key issue here is raising awareness of an issue and working with those that can help you to drive change. So who are the different stakeholders? There's a list of different people, but essentially it's anybody with an interest in blood cancers, anybody who you can work with and who's willing to work with you, including policymakers, payers, pharmaceutical companies, clinicians, and most importantly, patients. So when we talk about access, often we talk about change, we talk about access, we're talking about the same things a lot of the time. Normally what we want is access to the latest new drug or treatment. That's mostly where we get involved in engaging with different stakeholders. But also we're talking about things like prompt and accurate diagnosis, information about the condition for patients, and practical and emotional support. So when you're meeting with different stakeholders, what do you need to think about? Firstly, you need to know what your message is. Why are you meeting with them? What information is it that you want them to know? Why is this information important to them? What can they do to help you? So that's why you're meeting with them in the first place. And also consider what information it is that they want to know. Why are they meeting with you? What is it that you can do to help them? So, in terms of what you want them to know, a lot of the time this is the views of patients. Try and summarise what you want them to know in one key sentence. Set out what it is that you hope to achieve, and often this will be access to a particular drug for patients. But also, if you have evidence of what it is that you want, use this. This will help to persuade them using patient stories, the differences it's going to make to their lives, and also evidence and data. If you have evidence and data that you can collect, try and tailor this to your audience. So if you're getting in touch with a local decision maker, if you can do local evidence, that's much stronger. If you're getting in touch with a national decision maker, try and use national evidence. So we've already told them what it is that we want them to know. What do they want to know? Often it depends what they want to know. They might actually be in HTAs, for example, in the UK, actively seeking patient views. They may be open to what it is that you have to say. Or in other situations, it might be that actually they're not interested in what patients have to say, and you're trying to change a decision that's already been made. In this case, it will be much harder to engage with them. But in both situations, you need to remember, you are there to represent the patients. You have the patient's perspective with you. It's a unique insight that nobody else has. Policymakers, payers, pharmaceutical companies, they find it extremely difficult to gather this evidence. And the only people who can do it appropriately and effectively are patient organisations. So you're there to add context to decisions that they're going to make, and also try and explain how what you're telling them, as well as helping patients, how it will actually help them, whether it will improve outcomes for patients, save money, reduce hospital stays. Try and look in a way that's going to be beneficial for them as well as patients. So how and when to engage? So essentially, there are two different ways of engaging. The first one is reactive, where you're responding to something that's already happening out there and you don't have much control over the timescales, which that's the case for most situations, but is not the ideal way. The ideal way is proactive. You go out and you seek the change that you want. Try and engage with them early, before decisions have been made, and continue to engage with them throughout the process. So, turning our attention now to the specific stakeholders involved, who are we talking about? It varies based on country, but we're talking about policymakers, payers, anybody who has the power to make a decision about funding particular drugs or any type of positive change for your patients. It's important to remember that your reason for engaging with them may differ, but with each of the different stakeholders, the key is communication. A common example of a policymaker is HTA bodies. What drugs to fund? Which patients are they going to fund them for? I've already mentioned the unique insight that you can bring. Sometimes you may actually have to go beyond this, though, beyond the existing process, and call for wider change. Here's an example from the UK. We've already heard Nick's perspective on UK HTAs. We have separate HTA bodies in each of the separate countries. We have different decisions, different processes, different drugs being made available for different groups of patients. This is a lottery for CLL patients as to which drugs they can access, and it's based simply on their location within the same country. Earlier this year, the system changed so that drugs that were previously funded via something called the Cancer Drugs Fund now had to be assessed by NICE. Whilst NICE, and I'm sure many of you will be aware of NICE, undertakes a very robust evidence review, this makes it very hard for NICE to assess drugs for rare cancers, which includes many blood cancers such as CLL, which is why a lot of these drugs were funded via the Cancer Drugs Fund. So the changes, in essence, are drugs funded via one fund because the process doesn't suit them are now being assessed by the process that doesn't suit them. So we were extremely concerned when these changes happened about the fact that access to some of these drugs can be withdrawn. As of yet, all of these assessments are still ongoing and will be ongoing, many of them for the next year or so, until the end of 2017. So we don't know how all of this will change. But we think that the NICE system unfairly discriminates against these rare cancers such as CLL. And we have introduced a campaign called the Cancer Lottery Campaign, and we're calling for a separate appraisal process to be introduced in the UK, which fairly and flexibly covers rare cancers, taking into account things like quality of life and what patients are actually telling you. So on to a different stakeholder. I'm not going to cover a lot about pharmaceutical companies because we already had a talk on it this morning. But in some ways, pharmaceutical companies, the kind of discussions you're having, are actually quite similar to policymakers. They often focus around health technology appraisals, and pharma, like policymakers, have the power and resource to drive change, whether that's through clinical trials, new drugs, providing additional data, offering different prices. But I've already mentioned pharma companies find it extremely difficult to represent patient views and evidence without the help of advocates like the people in the room here today. The other thing pharma can do, which everyone will be well aware of, is pharma can provide funding. But as well as benefits, this creates a number of challenges. For example, how to engage with pharma but advocate for access to new drugs whilst you're receiving pharma funding, which the independence of some organisations can be questioned. It's important to have transparency, independence, and we've developed a code of practice where we set limits on the funding we will receive from any particular company, no more than 5% of our income, and in total from pharmaceutical companies, no more than 20% of our annual income, to make sure that when we're regularly advocating for new drugs to be introduced, that we are doing so completely independently. So another stakeholder is healthcare professionals, and this isn't just haematologists, but it's also nurses, psychologists, general practitioners. The clinical experts, often the haematologists, can help you to gather clinical information that you need for patient booklets or patient submissions for new drugs. But also, sometimes for different non-specialists, you need to share best practices across the country, drive changes in patient care. This can include things like signposting to accurate information and also holding events for nurses. In the UK, we hold nurse conferences to get together the nurses from haematology, share best practice about what matters to patients, providing information, and also other clinical expertise from haematologists. But we don't just engage with specialists, we also engage with general practitioners. In the UK, the general practitioner is usually the first point of call for blood cancer patients. They're central in terms of access to diagnosis. Normally, they will be first see a GP before then being referred to a haematologist. But in the UK, early diagnosis of blood cancers is a particular challenge due to the rarity and the non-specific symptoms. There's approximately 40,000 practicing GPs in the UK, but only 34,000 new cases of blood cancer are diagnosed each year. So on average, they're seeing less than one patient, and their usual appointment is 10 minutes. They're meant to be picking up these symptoms that are extremely rare and can actually indicate much more common conditions. So to combat this, we've been engaging with the Royal College of General Practitioners, which is their professional body in the UK, and we've been working to develop training for GPs to help them in spotting the signs and symptoms of blood cancers earlier. There was a report by the National Cancer Intelligence Network called The Routes to Diagnosis, which picked up that 30% of blood cancers were being diagnosed via an emergency presentation. This compares to a national cancer average in the UK of only 22%, and actually for particular blood cancers of the acute leukemias, for AML it was 53%, and for ALL it was 64% were being diagnosed as an emergency. So this training has been essential for GPs. We've been working hard to get it out. It's an online course that they can access for free, and it actually counts towards their professional accreditation each year to make sure they're understanding the needs of blood cancer patients and how to diagnose them as early as possible. On to the final and most important stakeholder is patients, and actually patient advocates such as yourselves. Engagement with this group is often very different from the other stakeholders. Mostly you're trying to gather patient views, often through surveys like we've already heard from Pierre, so that you can represent the interests of these patients when engaging with the other stakeholders through HTA decisions and discussions with pharma. You're trying to get both individual evidence of patient stories so that you can be emotive with patient quotes, and also collective evidence, data, surveys. But it's also important to actually feed back what you've been doing to your membership. Communication remains key. You need to keep them updated of past successes, future plans. Your membership are there. They can help you advocate and provide pressure. So how to go out and gather this information? I'm not going to go into it a lot. A lot of it's already available. You might have it on social media. You might have patient stories on your website. And if not, you might want to go out and do surveys, hold focus groups. I'm not going to go into that because we've already had Pierre talk about it. An example of what we've been doing, so a lot of our individual evidence, we run support services. We have a 24-hour care line where patients can talk to either other patients, but also we have a nurse advisor on the line, so we can gather information through that. We also hold annual conferences, national conferences, getting patients in from across the country, and also local regional meetings, which we call support groups, where we have small numbers of patients, sometimes under 10, but actually some of them, if they're held in a centre of excellence, can be 50-odd patients and more. All of these are opportunities to gather individual stories, which provide individual, independent, collective evidence, which is really useful for HTAs. The thing we've been working on recently, which has been to provide collective evidence, has been quite a big survey. In England, the NHS runs something called the National Cancer Patient Experience Survey, which includes all different types of cancer. Unfortunately, that means there's not a lot of specific questions about blood cancers. So what we've been doing is we've been doing a follow-up survey to that, which is 12 pages long. There's about 85 questions, and we're looking to publish this next year. So far, it's running at the moment. We've been running it for 6 weeks. We've got 1,800 responses when I checked yesterday, and we've got it running for another 6 weeks, so we're hoping to get many more involved. It covers lots of specific issues like watch and wait, stem cell transplants, but also more generic issues like diagnosis, information and support, gathering CLL specific information and information for other types of blood cancers. This information is being gathered through our membership, but also I'd like to take the opportunity to thank CLLSA, who've actually been helping promote it, and also MPN Voice. It's been crucial to get everybody involved to help gather so many responses. As well as engaging with patients, it's also important to engage with different patient groups. Obviously, we're here today doing just that. In the UK, we partner with a number of different key charities, either individually with separate charities or as part of other coalition groups. It enables you to increase your reach, increase your voice, and increase the numbers of people you can reach. It also shows a united patient voice and enables you to get in contact with key stakeholders and actually get them to attend your meeting. Because if you've got 2 or 3 different key groups having a meeting together, they might be able to come, but they might not actually be able to go to every single meeting. So a UK example of us working individually with another patient organisation is the CLL Support Association. We've been working together on a number of key projects, joint HTA submissions, responses and appealing decisions, holding joint meetings, joint support group in Cardiff that we have, and helping promote projects and services that each other are running, such as the survey I've already mentioned. Examples in the UK, we have a number of coalition groups. There's also obviously a number of international coalition groups, opportunities for sharing ideas and working together. Normally, these groups focus around a specific issue, and the key is to come together and discuss shared goals and with clear objectives. In the UK, we have a specific group that brings together all of the different blood cancer charities, because there's quite a lot of them. And also Cancer 52, which brings together all of the different different rare cancer charities, so that we can discuss issues that are common for HTAs with rare cancers, as opposed to the common ones and the small patient populations that are involved and the challenges that brings. We've also got a coalition of all different cancer charities in the UK looking at access to treatment and issues that we're all facing with NICE, and whether or not we need to change it to better include the patient voice, and obviously the different European and worldwide groups, such as the ones represented here today. So, in conclusion, my key messages are, firstly, have a clear message, set a clear and achievable objective, make sure everybody knows what it is. Base this on the patient views you've gathered individually and collectively. And thirdly, wherever possible, provide evidence. When you're trying to do all of this, don't try and do it alone. Work with other organisations, anybody who also has a similar remit, and also inform and empower your membership. They will help advocate and they will help raise awareness of an issue. So if you weren't listening to the rest of it, just listen to this, because it summarises everything in one sentence. Communication and working together with anybody with an interest in blood cancers can improve access to treatment, information and support, and that's the reason all of our organisations exist. Thank you very much. We're doing joint questions.
Yes. So thank you very much, Zack, for your complex presentation. And this is now the time not only for your questions, but also for your comments, as you might feel that something has not been addressed, and where else than here should be even the exchange of opinions. So please.
I'd like to address this to Zack and Pierre. Zack, you mentioned about publishing. I wonder, Pierre, have you thought about that? And what do you think about it's a lot of work to get stuff published. Do you think it makes a difference? Do you think it increases the credibility? Is it something that you're going after? My bias is that it makes a difference. If it's published data, then clinicians can refer to it, say this is important to patients. But I'd like to hear your two thoughts on getting your surveys, which are very important data, published.
So obviously at the moment the survey's still running, so we haven't published it anywhere. The first place we'll be looking to publish it as soon as the results are available, which should be at some point in the first few months of 2017. The first place will be on our website, just so it is actually publicly available and anybody who's interested can access it. Following on from that, we're looking to write reports, so a full report on what the survey shows, and then specific reports for CLL, MPNs, AML, ALL, different types of lymphoma, showing each of the different variations. So once we have those full reports, we'll be looking to publish those publicly wherever we can outside our own organisation.
Are you pushing to get them published in peer-reviewed journals? Because clinicians are depend on that kind of stuff. I mean, publishing it on your website, I think, is very helpful, but doctors can be very dismissive of that until it's peer-reviewed.
Yeah, when we have the report, we'll be looking to publish it in peer-reviewed journals wherever possible, and also showcasing it at conferences. But until we have the report, we can't do that.
So I can answer as far as CLC is concerned that we did publish the results on our website. As a matter of fact, our members, the website is available to all the members, to all public persons, and especially for the members. And well, among our members, we have got a lot of hematologists. So, I mean, it's a way to reach hematologists as well. But as Zack said, it can be used as an evidence in all lobbying action that we are undertaking. And that's something we do in France. And I think it would be important to focus the next survey also in this respect, knowing what we are asking to the decision makers, and that's the reason why we want to focus on the patient journey, because we know that with the new drugs, with a new way of taking the drugs, for instance, at home, etc., the compliance important, the side effects, etc., we will have to intervene before the decisions are made with evidences. And this new survey has to be, well, let's say, designed in this purpose. So it will be published anyhow, and hopefully used as a lobbying tool. Absolutely.
Pierre, do you plan to publish it in a peer-reviewed journal to take it to that level so it becomes part of the medical literature?
Well, I don't know. I think that the survey 2013 is a little bit old to be published. So I would prefer waiting until the new survey is available. So the results of the new survey are available. But you are right, it would be a good way to influence as well. Huh?
Yes. Other questions or
Can I just
comments?
add something to Pierre's comment?
Yes, Natasha.
Yes. Can I just add something to
sorry.
Pierre's comment very quickly before we move on?
Yes, please.
As well as trying to publish the information, one of the important things we really want to use this information for is health technology appraisals. So we specifically designed the survey so that it aligned with the questions we were being asked by organisations such as NICE, because even if someone else doesn't use this information, it's important that we can put it out when decisions are being made. I just wanted to add.
I had a comment actually about what Zack presented and what the activities they have to train general practitioners. Because I think that's something extremely relevant, because we did an internal survey among our members in order to understand which is the main issue for lymphoma patients in their country. And in, I would say, 9 cases out of 10, the first issue was not access to medicine, it was late diagnosis. Late diagnosis because general practitioners had just no idea, and because they do not see so many cases. So, and the involvement of patient organization in the training of general practitioners is an extremely good practice, in my opinion.
I could hardly agree more with you, Charlotte, because this is also a concern to comment on the fashion. It's an extreme concern now of the ECHO, so I can only provide this perspective being a member of the ECHO Patient Advisory Committee. So involving the general practitioners not only in improving the early diagnosis, but also in the afterwards care of the cancer survivors.
I was just mentioning that from our survey, we saw that 80% of the people, of the patients, have learned the diagnosing after a checkup. It means that checkups are absolutely necessary, not only for CLL, but for other diseases as well. And it may be a question of resources. I do agree with Natasha. The issues in Africa, for instance, or Latin America, are quite different than our issues. But if I see the tendency even in Canada and in England, excuse me, in the UK, that the access to the drugs are different from one region to the other, I wonder why the people are not moving in order to be treated.
They are.
They are.
They are.
Okay. Oh, so I mean, it's a global issue as well, and we should, I think we should, as CLLAN, have a look on the country that have not the not wealthy country, let's say, because it's an issue that is quite different, even for basis treatments, of course.